Hey guys, this is Anna Dunn, and I'm going to be presenting to you all about systemic lupus erythematosus. Systemic lupus erythematosus is a chronic inflammatory autoimmune process accompanied by destruction of tissues by B-cell and T-cell response to self-antigens. As you can see in the animation, typically B and T cells target and destroy antigens and allow self-markers to live peacefully within the immune system. Unfortunately, with lupus, there is a miscommunication, where the immune response has a compromised antigen detection system and self cells are targeted as harmful. Specific etiology of lupus and its manifestation in individuals is not currently known, although there is evidence to suggest a correlation with viral processes such as Epstein-Barr virus, HIV, and others, along with history of certain medications. Risk factors include socioeconomic status, stress, genetics, estrogen production, making it 90% more common in women than men, and more likely in younger women than older women, and race, where African American and Hispanic women are most at risk. Clinical assessment of a patient with lupus includes discussing their signs and symptoms and performing a thorough physical exam. As lupus is an autoimmune process, signs and symptoms and physical exam findings may vary from patient to patient. Some of the manifestations you may note during a workup include nonspecific symptoms such as during a viral syndrome, including malaise, fatigue, fever, and weight changes, musculoskeletal complaints such as arthralgias or joint pain, and arthritic symptoms, which present similarly to rheumatoid or autoimmune processes over trauma or overuse injuries, as common complaints include inflammation and pain in the morning with relief after use of the joint. Cardiopulmonary manifestations include cough, pleuritic pain or pleuritis, hemoptysis, dyspnea, and pericarditis. Neurologic symptoms may include headache, photophobia, or focal deficits. Dermatologic complaints include malar or discoid rash or photosensitivity. And GI symptoms may include nausea, vomiting, anorexia, or abdominal pain. The severity of reactions can range from joint pain to death secondary to organ damage. You may recall the SoapBrain MD mnemonic that we learned during didactic year. S stands for serositis, which includes pleuritis, pericarditis, or peritonitis. O is for oral or nasal ulcers, which present similarly to aphthous ulcers. A is for arthritis in greater than 2 joints. P is for photosensitivity, which means extreme sensitivity to the sun, leading to burning more easily after sun exposure. B is for blood disorders, which include anemia, leukopenia, thrombocytopenia, lymphadenopathy, and or splenomegaly. R stands for renal involvement, which means lupus nephritis, which we will talk about in a moment. A is for a positive anti-nuclear antibody test on blood work. I is for immunologic symptoms, N is for neurologic manifestations, such as discussed on the left side. M stands for malar rash, which is renowned for sparing the nasolabial fold. And D stands for discoid rash, which appears as round, deeper ulcerations, most commonly affecting the scalp and face. Differential diagnoses may include fibromyalgia, rheumatoid arthritis, and vasculitis. Fibromyalgia is a diagnosis of exclusion with no positive lab values. Therefore, any positive findings would imply a different process. Rheumatoid arthritis would have a positive finding for rheumatoid factor and CCP antibodies. And vasculitis would have similar lab findings to lupus in relation to hemolytic analysis and inflammatory markers, but a tissue biopsy would individualize this diagnosis. Though screening for lupus itself is not a commonplace, screening for lupus nephritis in patients with lupus is, where urinalysis is regularly conducted to screen for renal involvement. Urinalysis with hematuria, proteinuria, and or CAS will determine renal involvement and warrants further investigation of lupus nephritis with a renal biopsy. Classification systems exist to diagnose and prognose patients with lupus, such as the 1997 ACR, the 2012 SLIC, and the 2019 EU-LAR ACR, and yes, these are on MD-Calc. Upon symptom presentation, patients should first get a CBC, ESR-CRP, and ANA blood test to determine if more specific testing should be done for diagnosis. A CBC may show thrombocytopenia, leukopenia, or anemia. An ESR-CRP will be elevated, and an ANA would be positive. After initial workup is positive, certain ribonucleoprotein complexes, including Smith antibodies and double-stranded DNA, can be ordered as a confirmatory test and diagnosis for lupus. As stated before, renal biopsy is warranted following an abnormal urinalysis, and C3, C4, and double-stranded DNA are useful for assessing disease activity in flare-ups and treatment response. Intervention primarily depends on symptoms, frequency of breakthrough events, and tolerance to medication, with a goal of keeping exacerbations to a minimum and increasing length of time in remission. The mainstay of treatment includes a combination of glucocorticoids for flare-ups and exacerbations with antimalarial agents, such as hydroxychloroquine, which prevents exacerbations and serves as maintenance therapy. Steroids are the preferred method for treatment of exacerbations, thus improving the prognosis of patients with lupus, but consideration to severe side effects to long-term steroid use must take place. New evidence supports the use of B-cell targeting biologics, such as belimumab, which has shown to improve musculoskeletal and mucocutaneous manifestations and decrease exacerbations with less adverse effects than long-term steroid use. Beyond mainstay therapy, more targeted medical management is available based on patient presentation and clinical manifestations of lupus and their scores on classification systems. Early diagnosis and treatment have shown a decrease in mortality rate of 24.4% over a 46-year era. The most common and life-threatening complications of lupus include cardiovascular disease, lupus nephritis, and poor immunologic response and increased infection rates. Renal involvement and diagnosis of lupus nephritis are associated with poor prognosis, as it indicates high likelihood of multisystem failure. Although rare, hydroxychloroquine is associated with potential cardiac and retinal damage, but toxicity can be limited with intense blood level monitoring and ophthalmologic exams. Specialists should be part of the healthcare team for patients with lupus, such as a rheumatologist and possibly a nephrologist. A rheumatologist plays the major role in management of treatment and lab correspondence to monitor for complications of the disease and response or adverse effects to therapy. A nephrologist should be involved in cases of confirmed lupus nephritis, as even though it was one of the earlier signs of lupus, it is usually associated with poor outcomes unless it is classified as mesangial, as they have normal renal function. Lupus can affect all components of the heart: pericardium, epicardium, myocardium, endocardium, and circulation, but most commonly presents as pericardial effusion that progresses to pericarditis. Therefore, a cardiologist should monitor cardiac function in patients with lupus. Here is a short list of references that I used for my presentation. Thank you all for watching.